Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Sarah Medeiros
and Julia Magaña. Welcome back to part 2 on oncological emergencies.
If you remember from last time, we are here with our colleague, Dr. Monica Wattana, who's an emergency medicine physician specializing in oncological emergencies.
In the first part of this series, we spoke about communicating those incidentalomas to the patients, treating febrile neutropenia, anemia, and diarrhea. Oh my!
So now we're going to circle back to the issue of pain, as well as some of the ethical dilemmas that we face in the care of patients with cancer in our EDs.
And this is important because in a 2021 review of the National Syndromic Surveillance Program, pain was the most common presenting symptom for patients with cancer seen in the emergency department.
Monica, I want to come back to one of the core symptoms that you talked about early in the first episode, which is pain. We know that pain is a very common complication and often difficult to treat in our patients with cancer. What is the latest approach to cancer-related pain? And are there any algorithms or recommendations we can turn to?
It's such a difficult topic because pain in the cancer patient population is also multifactorial. And a lot of the current algorithms, like the World Health Organization scale, it doesn't take into account that most of our patients are on chronic opiates. And a patient that's been on chronic opiates has different thresholds and different issues when compared to an opiate-naive patient. And so in the emergency department, I think we're more used to working with opiate-naive people. And I don't think we have a lot of education on, how to rotate opiates, how to calculate your 24-hour morphine equivalent dose. And these are important things because patients presenting with pain, it's pretty much the number one reason why patients will come to the emergency department. I think patients that are presenting to the emergency department with a cancer diagnosis who are on chronic opiates, I think we can definitely do better at treating by increasing our education on how to properly dose them while they're in the emergency department and potentially initiate rotation of an opiate with consult with their outpatient pain doctors as well.
Okay, Monica, so this is your opportunity. Properly educate us. Patient comes in with increasing pain and has a workup. There's no new complications. There's no real cause other than just this is progression of disease. Let's say that they're on oxycodone at home. What do I do to help control their pain better so that they can go home and be comfortable?
So the first thing I would say is believe them. A lot of these patients, they're not going to be like screaming at the top of their lungs. They've lived with their cancer pain for a really long time. And so even if their pain score is 10 out of 10, usually they're not shouting in pain. And so believe them and also get a good history. Are they taking their medications correctly? And how long have they been on the medication for? Because if you've been on oxycodone, but you've been taking it sporadically, then I might not want to change anything. I might want to educate you to take it around the clock or take it more than you have been and increase the frequency only. Also, when they're in the emergency department, I still am a fan of the 0.1 mg per kg dose. You can start there, but the important thing to do is recheck soon, because if you give them one dose and then come back in like an hour and a half, you don't know if it actually worked well or not, because IV morphine, it doesn't take long to work. And so, I like to come back within 30 minutes to say, hey, has your pain scale decreased at all? We only really have that pain scale, 0 to 10 as a way to measure in the emergency department. But it's actually pretty helpful because in the pain clinics, they use it as well. So they can tell you. And so then upwardly titrate as necessary. You can start with the 0.1 mg per kg dose if they've been on chronic opiates for a while, but that's not where it ends. You have to reassess them frequently. And sometimes, if you're already dosing them every, 30 minutes, like twice, that's when I will call in for help with our pain specialists. Or I have a few colleagues, we're actually trying to work on an algorithm to upwardly escalate opiates through the emergency department that would use a PCA as well, because sometimes these patients just need it. But just realizing that the way they present with pain isn't like a person that is opiate naive. You're not going to see any yelling or shouting, but you need to trust that they are actually in pain as well. Also, be cautious and make sure that there isn't anything else going on, such as depression or something else that's making the pain worse. Understanding the etiology of the pain is going to be important too. So is it nociceptive? Is it neuropathic? Because if it's neuropathic, it's just harder to treat with opiates, and getting other medications on board, or even the pain specialist early. Our pain specialists can do wonderful procedures and do blocks on different areas that are actually more helpful for patients with neuropathic pain too.
Do you have any recommendations for treating neuropathic pain when opioids have been unsuccessful?
So this would be for my pain colleagues, because nothing really works immediately. Antidepressants are usually something that you could add on with addition with opiates, because a lot of times the pain is a mixed picture, but that doesn't work immediately. And so that's why I also am really pushing for observation units for these patients, because you might not need to fully admit a patient, but making sure that the medication works is important. And then transitioning patients after you calculate their 24-hour morphine requirements to an oral, that takes a little bit of time too. And so it's longer than an emergency department stay sometimes to really adequately make sure that these patients get the right treatment that they need.
Let's talk about end-of-life care in the emergency department. Monica, what is the role of palliative care in the ED for patients with cancer, and how does it different from the approach to curative care?
I think that's an important question, because a lot of us think that palliative care means and equates with hospice, when it really shouldn't. So palliative care needs to be started early. And I know that there are a lot of studies that are already showing that palliative care is usually initiated too late in patients. So palliative care means symptom management at our institution. And so symptom management as well as psych and emotional support too. It's a whole bundle. And getting these resources started early actually is really important, so that the patients can better thrive on their therapeutics.
What do you think the ED physician's role is in terms of determining goals of care for that patient in the ER?
This is a great question, because I just did a study, and we're going to be publishing it, where we asked the oncologists as well as emergency medicine residents and physicians in 5 institutions what their perceived gaps are in EM education and, issues that for oncologists that they perceive their patients face when they come to the emergency department. And one of the interesting things that we found was centered around goals of care. So oncologists actually are not really keen on having the emergency medicine physicians, from my study, talk about goals of care in the ED. And I want to give a little bit more of a background, because cancer therapeutics are being advanced. It's almost like overnight I read a new study, or overnight we're adopting a new treatment. And a lot of these patients are failing multiple lines of treatment initially. So they're frail, they look really, really sick, but they're still on these different treatments, and there's still hope for them. And so we might not be seeing what the oncologist is seeing. So we might think, oh, wow, this patient is really end of life. Yes and no. And so I think that's why oncologists are a little hesitant to have us have these discussions without, consulting them first. On the flip side, unfortunately, we as emergency medicine physicians are having these discussions routinely. And the only way that I can bring things together is trying to, tell people to reach out to a patient's oncologist. What seems like it could just be a hassle would actually really help in terms of your patient workup and the transition from a patient being discharged or even admitted to the hospital, if you have the conversations with oncologists early, so that sometimes they can have a call with their patient once they kind of figure out what's going on first, and you guys can be in agreement. Because if you're thinking that someone is super end of life, and then that's how you're talking to them, and then the patient gets discharged, and then they go back to clinic, or the patient is seen by their oncologist inpatient, and they don't agree, it can be a little bit difficult. The only change and the only difference is when the patient goes to the ICU. That's when they're really critical. And so it is our job to have these goals of care discussions, because aggressive interventions may be needed, and you really need to know what their wishes are, because I don't think any of us wants to do anything that our patient wouldn't want done to them.
Are there any professional resources for those that do feel like they have a gap in their education on how to have these conversations that you can refer us to?
Sure. I think even if you have these conversations regularly, like we do at MD Anderson, there's still room for education. The good news is that there are different protocols that are out. Like we teach residents and trainees the SPIKES protocol. It's an acronym that stands for setting up the interview and creating privacy. The P is understanding the patient or family perception. I is inviting basically to see when you give information, how the family or the patient receives it. And then K is knowledge sharing. E is giving space and time for the patient and the family to respond. And S is a strategy and summary. And so, yes, there's protocols, but really putting them into practice is the most important. And so I know that there is a course in Chicago that I had taken, the emergency medicine palliative care course, which is really helpful. We are designing, and it's going to be in its first round next week, we are designing a goals of care, symptom management, and conversation class. It's a post-conference course after our Oncologic Emergency Medicine conference, because this is not a one-size-fits-all approach. And even palliative care discussions with patients with other longstanding comorbidities like CHF, there's differences and nuances when you take it to the cancer patient population that we want to address too. There's also things that I want to tell our colleagues about providing culturally competent care. And also, religion is also something important too. There's a lot of factors that need to be thought of when you're having these conversations that normally we might not think about that actually matter a lot.
Monica, how do you deal with it when the patient or family's goals conflict with those of their primary oncologist?
For me, it's easy because I get the oncologist involved. It's always better to involve the oncologist, especially if they've had these conversations prior. Now, it's also common that, patients' status might change. That will require me to step in when I'm seeing them in the emergency department. In that case, I really try to call the oncologist if I can. Now, if they're in the resuscitation room and I'm about to code someone, that's not a possibility. But kind of getting a sense of what's happening in terms of their treatment is going to be important so that I can kind of get a sense as to what their expectations might be and what their expectancy is or what is able to occur. You always want to do what's best for your patient. Think of it as most patients want a good quality of life. If I do not foresee that they're going to have a good quality of life, and I ask them that, what does that mean to you? I need to make sure that I am not doing an intervention that might promote suffering.
Can you share any examples of ethical dilemmas that are related to cancer palliative care in the emergency department and how they were resolved?
Ethical dilemmas are always difficult because a lot of times they happen during high-stress situations, either when you're coding a patient, when can you stop, or should you actually decide to, do aggressive interventions such as to intubate or to code a patient in the first place. A lot of times cancer patients might not think that, they are at end of life. And this is something that is really common, especially with these newer therapeutics treating patients that have failed multiple lines of treatment. And so you might be the first one to say, this is really not a good idea. Coding situations, nobody really understands it unless you're in healthcare. They don't understand what actually happens. And so with the patients, they're like, yeah, please intubate me, please do chest compressions. But all of these aggressive interventions aren't without side effects. And so having the discussion with the family or the patient saying, this is what I will do to you. You just told me that your quality of life and what you want is this, but I can't promise that. It could lead to moral injury for the providers as well because things are not congruent. I do say if you have resources available, sometimes you don't have an ethics team available like overnight. Sure, fair enough. But social work, or having someone else that can be there to help with these discussions will be important to help with the ethical dilemmas. Now, also sometimes another dilemma would be, religion. If a provider's religion or a patient's religion is different and they want something else than what you want for treatment. Like if you're someone that, you're bleeding out, but you can't accept blood. And it's something that as providers, you have to honor a patient's wishes. I think that's first and foremost, and try to do no harm. It's an oath that we took that encompasses a lot, but if me coding you is going to cause so much harm and I can't promise you that you can get off the vent, that's harmful. If your wish is to not want to do anything and I look at you and I say, I can really, really help you out, and this is not a life-threatening thing and it could be preventable. That's also an ethical dilemma, but it's what my patient wants first. And so it's something that you might see more often than not. What I would say to my colleagues is take time to process all of this. There's a lot of stress that can happen because of these ethical issues that I want to make sure that for my colleagues, you're taking time to take care of and process as well.
We have heard you say many times, talk with the oncologist, and that seems very logical to me. Obviously, communication is crucial in an emergency situation. How can emergency medicine professionals effectively communicate with oncology teams to ensure seamless care transitions?
The first thing is talk to the oncologist early. Now, I don't know in the community if it's easy to, reach someone at 3 a.m. in the morning, fair enough. But if there's previous records or anything, just understanding what the treatments have been or reading the last few notes, if you have an open system where you can see what's been going on in the clinics, is helpful so that when you have these conversations with the oncologist, they can understand what's going on as well. Calling them in the middle of the night, sometimes they don't have their computer on, and so it also jogs their memory. The second thing is patients usually have it's called my chart here, but ways to communicate with their oncologist. So a lot of times I will say, just send a note in that patient portal to say that you're in the emergency department. It's really helpful because someone on call will see that as well, and they can kind of follow up. I think those are the main two things. I work in a place where it's a little bit different because we always have someone on call for every single type of cancer. And so it's like this ivory tower thing. And so even where I practice, understanding what the patient has been going through in the last week. Is there any new medications? Is there any new experimental treatments that I can discuss with the oncologist about? And then also, I always look and see what their code status was prior to. It's something to just kind of get a sense of what's been going on too. And if there was a code discussion prior, if it's something that I might need to address down the line. If I'm talking to oncologists, then I'd rather talk to them about that as well.
On the pediatric side, we also have ivory tower status and get to access our oncologists who want to know about everybody and everything. They're very, very invested in our patients. But Sarah, what are your recommendations if you don't have immediate access or have that kind of I want to know about it relationship? What have you seen work well in the community and on the adult side where you don't have that immediate access like we do?
Yeah, I think it's a challenge. I mean, we are at an academic institution where we actually have an oncology consult, or we can message the primary oncologist. And I frequently do that, and it's hit or miss. Sometimes I get a message back immediately. Thank you so much for caring for my patient. We'll take it from here, or we'll follow up with them, or whatever. I think it's more challenging in the community. If you are at a critical access hospital or in a rural area and their primary oncologist is at a different institution, trying to even find that number to reach out to them can be a real challenge, especially if you are in a single coverage ED and it's busy. So I think this is going to be an ongoing issue. And to be honest, you might pick and choose which patients you're going to take that extra effort to make that call for. Obviously, you'd love to do it for everybody, but you may have to choose who are these patients who are maybe not so sick that I need to transfer them to that institution, but sick enough that I'm concerned about them, or I don't know what to do in this instance and I'm worried about something specific to do with their cancer, and then trying to reach out. It is challenging for me, even at our institution, to reach someone after hours or on weekends who knows anything about that specific patient.
I also want to add, trust your judgment as well and err on the side of caution. If something doesn't seem right and you want to observe for a little while longer, I would do so. If you can't touch base with an oncologist and you're unsure if they can get good follow-up, it might warrant a little bit more observation as well.
One other thing I'll throw out there is that patients and families often have a direct line to their oncology team, whether it's the oncologist directly or a care coordinator. So if you don't know how to reach them, talk to the families and patients themselves because they often will have that liaison.
Okay, so we've identified that there are challenges and sometimes with that ideal situation of getting hold of the oncologist and coming up with the best team plan. And at the same time, this is a bit of a gap in our education. Monica, where do you recommend that our listeners can go to help fill that gap even more and be able to access this resource or access resources on their own?
There are a few textbooks out. I have my book that it's more of a bullet point, very concise reference. We have a Oncologic Emergency Medicine conference that happens annually at MD Anderson Cancer Center. The next one is coming up at the end of this week. And that's a good place to get updates on just bread and butter topics, along with getting a sense of future directions and future things that are pertinent to emergency medicine. Our emergency medicine education probably trails what's happening in the cancer world by like 10 years. And so even what is on our core content under the oncologic emergency section right now, and I think that it was updated in 2022, it really trails as to what is happening in the actual world and what you're going to see in the community. Getting updated on the newer therapeutics, I think is going to be really key for our community listeners. So immune checkpoint inhibitors was recently added. And even within immune checkpoint inhibitor treatment, recognition of side effects within the last 3 years, there's been so much changes. And so we don't routinely give steroids to everybody. There's different algorithms that are currently being in place just even for that. And that was the recent therapeutic that was just added. You have chimeric antigen receptor treatment. So CAR-T is another new thing, and bispecific antibodies are going to be also new. And recognizing ICANS and CRS is going to be important. CAR-T and bispecific antibodies aren't on our radar just yet in the emergency medicine world. And you're going to see a lot of it because a lot of it's outpatient treatment. And so really recognizing all of this stuff. Neutropenic fever in a patient with CAR-T, there's other things that you need to work up and do, or, understanding transfusions and other stuff in patients that are receiving these other investigational medications. There's a lot of interactions that might happen, or, nausea medication treatment. And so there's a lot of stuff that's happening that we're just trailing. And so just realize that the need for education, even if you've been out and had, really robust training in residency like I did, you're going to always have to be learning and adjusting how you're practicing, because I feel like every single time I go into the emergency department, I get a new notice about something that's new.
Was there anything else you want to add?
I just want to tell people that if anybody is interested, this niche is such a new niche, but it's only going to grow. The amount of cancer patients that are going to be visiting emergency departments is only going to be going up. And so, having this be your new niche would be awesome for the trainees out there, or even if you're practicing, learning more and really being the advocate and the expert for cancer patient care in your shop is a wonderful thing. And so I just want to advocate for the continued pursuit of learning and care for our patients.
Believe your patients when they say they're in pain. Calculate their daily morphine score and consider rotating opiates.
For neuropathic pain, nothing really works super well. Opiates are less helpful, but may be done in conjunction with other modalities such as antidepressants and nerve blocks.
These are sensitive conversations. Be intentional about the setting, provide empathy, share what you know, and give space to process.
When you run into an ethical dilemma, keep it patient-centric. Take personal time to process the stress associated with dilemmas.
Create a standing relationship with your oncology team. Try to get a hold of the patient's team early and/or encourage your patients to send a note with inside of their patient portal.
Take a moment to go even deeper into this topic. Attend a conference, read a book, Dr. Wattana's is linked in the show notes, and educate yourself on this topic. Well, that sums up oncological emergencies. I hope you learned something. I know I did.
If you did learn something, consider sharing the podcast with a colleague. Maybe they will learn something too. And follow us at EM Pulse Podcast.
Thank you to our department for supporting ongoing education.
And thank you to OM Productions for supporting our own ongoing learning curve.
And hey, if you're a trainee out there and this resonates with you, consider Oncological Emergencies as a fellowship option.
Until next time, stay curious, stay inspired, and stay tuned.